Hello everyone. Today we are going to do the last part of the cranial nerves, and this is going to be the medullary division. So these will include the cranial nerves that are derived or originate from medulla. So in the coming slides we are going to discuss the remaining cranial nerves, and these include the cranial nerve number 9, which is the glossopharyngeal nerve. We have cranial nerve number 10, which is the vagus nerve, number 11, the spinal accessory nerve, and number 12, the hypoglossal. In this, we are going to learn the branches, their innervation, functional components, and the pathologies that are associated with them in details. Let's start with the glossopharyngeal nerve. The glossopharyngeal nerve is number 9, and there's 5 functional components of the glossopharyngeal nerve. Number 1 is the general visceral afferent, special afferent, general somatic afferent, general visceral efferent, and the branchial efferent that includes the muscles of the third pharyngeal arch, which were supplied by the glossopharyngeal nerve during the embryonic development. The glossopharyngeal nerve exits the skulls via the jugular foramen. There's two basic functional components of the glossopharyngeal nerve. The overview includes the sensory functions and the motor functions. The sensory function include the taste and somatic perceptions that include the touch, pain, temperature of the posterior third of the tongue, proprioception of the swallowing musculature, the sensory innervation of the outer ear, and one of the most important functions is the baroreceptors and chemoreceptors in the carotid body. And that will assist in the blood pressure control, and that will in turn monitor the oxygenation and carbon dioxide content in the blood. The motor function, so that include the innervation of the palate and the muscles of the pharynx. It will also do its work with the dilation of pharynx during swallowing and speaking, and finally it will help in stimulation for the salivation when the person is going to eat the food. Now let's look at each functional component in detail. Let's start with the general visceral afferent. This will provide the sensory information from the carotid body and the carotid sinus. The baroreceptors, baro means pressure, so the baroreceptors in the carotid body will assist in the blood pressure regulation, and the chemo, which is chemical. So chemoreceptors in the carotid body will monitor the oxygen and carbon dioxide contents of the blood as the part of the ventilation regulation. So over here, you're looking at general visceral afferent, so you're going to have to look at the blue part. So this is usually the carotid body is present right here at the bifurcation. So you will see the carotid nerve going up, and it is making its synapse right there, and hence it's going back up in the medulla. The next one is the special visceral afferent. This branch of the glossopharyngeal nerve will provide the sensation or taste from the posterior 1/3 of the tongue. Remember the facial nerve in our previous lecture. The facial nerve will provide the innervation of the anterior 2/3 of the tongue. The posterior 2/3 is provided by the glossopharyngeal nerve. So let's follow here. Special visceral afferent, and this is the posterior part. So the taste and general sensation of the posterior 1/3 of the tongue, including the circumvallate papillae. So it goes up, make a synapse right there, and then the glossopharyngeal nerve is like all coming down together, and it is getting innervation right here. So this part is getting innervation or the final termination in the nucleus of tractus solitaris. The third functional component of the glossopharyngeal nerve is the general somatic afferent, and this innervates the musculature of the tongue, palatine tonsils, oropharynx, mucosa of the middle ear, and pharyngeotympanic tube and the mastoid ear cells. So you see here in the diagram, you have all the tympanic plexus and list right there, and this is the optic ganglion tympanic nerve going up right there. Then we have the general visceral efferent. This will innervate the parotid glands, and synapse happen in the optic ganglia. So remember the synonym GOP. G stands for glossopharyngeal nerve, O means otic ganglia, and P means parotid gland. So you see the secretomotor fibers of the parotid gland making a synapse here at the optic ganglion. There's a tympanic plexus and the tympanic nerve that goes up right here into the inferior salivatory nucleus in the medulla. You can remember this with GOP, which is the Grand Old Party, or that is the Republican Party, but hence glossopharyngeal does not include the Republican Party. We can just use that synonym with the glossopharyngeal otic ganglia or glossopharyngeal nerve, otic ganglia, and parotid gland. Then the last one we have is the branchial efferent or the third pharyngeal arch, which innervate the stylopharyngeus muscle. This is the muscle that is derived from the third pharyngeal arch. Hence, during the embryonic development, glossopharyngeal nerve will provide innervation as well. Let's look at some clinical points for this nerve. So, any damage to the glossopharyngeal nerve will cause, of course, pain. There is a problem impairment. There is a problem and the impairment for the taste and swallowing to the posterior 1/3 of the tongue. There is a loss of sensation from the soft palate, and there is a loss of gag reflex. So when you do a physical examination on a patient and the gag reflex is impaired, imagine that glossopharyngeal nerve is damaged somewhere. What are the causes? Tumor, of course, that's the most common one. We have infarction. Then we have a compression from the neighboring artery. So of course, the pulsation from the adjacent artery will cause the demyelination of the glossopharyngeal nerve. Let's move on to the next cranial nerve, and that is the vagus nerve. The vagus nerve has multiple functions, hence the name means wandering nerve. The wandering is basically it's going everywhere inside the body. It is originating from medullary region and exit the skulls via jugular foramen and supplies the multiple array of the organs all the way into the abdominal cavity. The functional component again includes the general somatic afferent, general visceral afferent, special afferent, general visceral efferent, and the branchial efferent. That means supplying of the muscles that are originating from the fourth pharyngeal arch. So in the coming slides, we will look at each functional component of the vagus nerve. Functional consideration, let's start. Number one, sensory function, and number two, we have the motor functions. The sensory function include the taste and sensation in the epiglottis and the pharynx. Again, we have the baroreceptors in the carotid and aortic bodies assisting in the blood pressure monitoring. Then we have the monitoring of the oxygen and the carbon dioxide content in the blood for the control of ventilation and sensation in the thoracic and abdominal organs. That is the sensory functions. The motor functions for the vagus nerve is the swallowing, coughing, and speech. And now you also have to include the parasympathetic functions that are associated with vagus nerve. We have discussed that in detail in the parasympathetic slides. Please go back into the playlist and you will find that. It includes the contraction and relaxation of the smooth muscles in the GI tract, the secretion of the digestive juices, the reduction of the heart rate, and assist in the control of the renal functions. Let's start with each individual functions. So general somatic afferent, it includes or provides the innervation to the larynx, laryngopharynx, the deep part of the auricle and part of the external acoustic meatus, and the dura mater of the posterior cranial fossa. The other cranial nerves do the anterior, middle, and this one do the posterior cranial fossa. Then we have the general visceral afferent. It is providing sensory innervations to the aortic body chemoreceptors and the aortic arch baroreceptors. We have esophagus included there, foregut and midgut derived viscera, bronchi, lungs, and the heart. The special afferent, this portion of the vagus nerve will be conveying the taste from the epiglottis and pharynx. Then we have the general visceral efferent. So that will provide innervation to the smooth muscles and the glands associated with the pharynx, larynx, thoracic organs, abdominal organs derived from the foregut and the midgut. And then we have finally the branchial efferent. And during the development, the vagus nerve innervated the muscles that are derived from the fourth pharyngeal arch, and that will include the palatoglossus, muscles of the soft palate except the tensor veli palatini, the muscles of the pharynx except for stylopharyngeus, and the muscles of the larynx. Let's look at the clinical relevance. The damage to the vagus nerve will result in the different pathologies, so that depends on which area is involved. However, the overarching pathologies will cause the impairment in the GI motility, swallowing, and speech. It will be fatal for the patient if the damage is bilateral. Some instances include the loss of gag reflex, vocal cord paralysis, uvula deviates from the involved side, and dysphagia. The causes, of course, the most common one is tumor, infarction, and penetrating neck injury. Now let's do the second last cranial nerve, which is cranial nerve number 11, the spinal accessory nerve. Functional component is only one. It is a general somatic efferent nerve, hence it has a motor functional components. It will involve the musculature of the shoulder and neck, and the muscles that are innervated by the spinal accessory nerve is sternocleidomastoid and the trapezius, and it exits the skulls through the jugular foramen. The motor function is involved in the movement of the head and shoulders, and clinical consideration, the damage to this nerve will cause the head to turn towards, this is important, towards the damaged side, and that damage to the nerve will also cause the shoulder pain. You will also see the impairment of abduction at the shoulder, and then there is a weakness in turning chin to the opposite side. Causes, of course, is again the most common one is tumor. Then we have the penetrating or blunt injury to the distribution of the nerve. The final cranial nerve for this series is the hypoglossal nerve. Functional component only include the general somatic efferent function, and this nerve innervates the muscles of the tongue. Hence, it has a motor control function on the movement of the tongue. It exits the skull via the hypoglossal canal. Innervation, the muscles that are supplied by the hypoglossal nerve include hyloglossus, genioglossus, styloglossus, and intrinsic tongue muscle. So basically, most of the muscles that are associated with tongue are involved with the hypoglossal nerve. Clinical consideration, the damage or the pathology of the hypoglossal nerve will cause the difficulty in speech, atrophy of the ipsilateral tongue due to no nerve input, and the deviation of the tongue towards the affected side on protrusion. That's important. Causes, again, tumor, most important one, most common one, infarction, infection, neck injury, amyotrophic lateral sclerosis. You will also come to see that INSPIRE treatment is also the hypoglossal nerve treatment that usually is done as a most advanced treatment for the sleep apnea for the patients, especially that cannot tolerate the CPAP or other treatment modalities. Then we have the INSPIRE, that is one of the most coming advanced and most commonly being used right now for the treatment of the sleep apnea. With this slide, we're going to end our discussion here, and in the coming slide, we're going to start a new chapter, which is the spinal cord, and we're going to discuss that in most important stuff over there, especially the high yield topic. Thank you so much for following, and I will see you soon.